All right, we're going to go ahead and get started. It's a little bit after 7. So I know COVID and switching the venue for grand rounds around has wreaked havoc in terms of in-person attendance. So I'm speaking to all of you out in the Ethernet, as well as those not attending grand rounds today. We're going to try to ramp up our in-person attendance. It should be much easier now that we are back in the Schroeffel Auditorium, and this is where it's going to be in, I hope, perpetuity. I want to thank our CEO, Tom Grono, who moved a lot of mountains to make this happen so that we could have grand rounds back here. And I know we're all running back and forth between the pre-op area. This is going to make it so much more simpler. The other thing I wanted to make sure that you're aware, we have 2 upcoming visiting professors. And with visiting professors, I do want everyone to come to the Bruce Schroeffel Auditorium. And I realize there are people in other cities or maybe in another hospital, and that's just impractical. But I would like everyone on campus to not do this virtually, but to show up in person, please. We have Dr. Punch coming on February 13th, and a good friend of mine who I trained with, Dr. Espat, coming for the Swan Lectureship on March 13th. Okay, so it's easy to remember the Mondays that fall on the 13th. Okay, so we have lined up another 2 great speakers and topics this morning. Our first speaker is Dr. Ethan Cumbler, who will present on patient-reported outcomes use in surgical practice. I think all of you know Dr. Cumbler very well, but you may not know all of his history. He's a professor of both medicine and surgery. He's director of quality in the Department of Surgery, which is soon to expand as we build out our vice chair role. He's the past president of the medical staff at UCH. He's founder of the Institute of Quality, Safety, and Efficiency here on campus. He holds or has held about 20 other leadership positions. He did his undergraduate at University of Wisconsin, did his medical school at University of Kentucky, where he graduated AOA and #1 in his class. He did a combined peds and internal medicine residency at Good Sam and Phoenix Children's. Was in private practice for a few years, but decided that wasn't the way to go and came back to academics and came to CU in 2006. Since then, he's won really too numerous to count quality, clinical, and teaching awards. He's extremely active in that space and holds a lot of research grants and projects. He's mentored over 70 trainees by my count, some of them surgical residents and faculty. He has saved many lives by working with us and helping our leaders, as well as co-leading some of the projects. I'll just give you some examples: VTE prophylaxis, ERAS pathways, CAUDIs, colorectal SSIs, and many others. He's extremely well published and is a great leader, and we are so happy to have him as a leader in the Department of Surgery. Dr. Cumbler, thank you.
Well, good morning to those of us here in person, those who are virtual, and those of us who accidentally showed up at the Fulganetti Pavilion. It is my great pleasure today to talk about an area of both research as well as clinical quality improvement interest of mine, and I suspect is going to be of great interest to all of you, either now or in the near future, which is patient-reported outcomes in surgical practice. But before we really delve into the literature on patient-reported outcomes, I thought it would be worth considering, at least for a moment, the evolution of what we think of as quality in surgery in the first place. And so I would pose the question, if we went back to the early 19th century, what is quality in surgery? But I submit to you that if you're talking about the pre-anesthetic era, it's speed, right? So the painting that you see pictured here is the great Dr. Robert Liston. And Dr. Liston's career spanned the pre-anesthetic and the anesthetic era. And during the former, he was known as the fastest knife on the East End. And Richard Gordon, a surgeon contemporary of his, described Dr. Liston's technique, and I will read to you his words. He sprung across the blood-stained board, calling, "Time me, gentlemen, time me," to students craning with pocket watches. Everyone swore that the first flash of the knife was followed so swiftly by the rasp of saw on bone that the two seemed simultaneous. To free both hands, he clenched the bloody knife in his teeth. Now, one can only imagine for the students in the back of the room what it must have been like to be a student in his operating theater. Now, Dr. Liston's record for a leg amputation was 2.5 minutes from incision to closure. We will live with our closed captioning. So Dr. Liston's record was 2.5 minutes from incision to closure, which is, I think we would agree, impressive. But in haste, there are occasional missteps. And in the process of removing a leg on one occasion, he accidentally also removed both testicles, solidifying his record as fastest orthopedist and worst urologist. But I submit to you that this paradigm of surgical quality is inherent in the technique of the surgeon remained dominant for hundreds of years, and in fact is mocked to this day in cartoons and memes. Now, that brings us to another pioneering surgeon in surgical quality, which is the great Dr. Ernest Codman, a man ahead of his time, a founder of the American College of Surgeons. Dr. Codman was a Harvard man. He practiced at Massachusetts General Hospital. He was the originator of the Morbidity and Mortality Conference and originator and chief proponent of what he called the end result idea. His fundamental premise, captured in this quote, "Every hospital should follow every patient it treats long enough to determine whether or not the treatment was successful, and then to inquire, if not, why not," rings true to this day. Now, he would track complications and the end outcomes out to a year after surgery on index cards that he referred to as his end results cards, one of which I have pictured on the screen here today. Now, controversially, he also believed that this data should be available to the public and used to compare surgeons and hospitals as they make their decisions about where to seek care. And so for his pioneering work in surgical quality, Dr. Ernest Codman was promptly kicked off the medical staff of Massachusetts General Hospital. Now, I would argue that Dr. Codman really ushered in the modern era of surgical quality. And for me, at the beginning of my career, this came about as a series of measures that were introduced by the Joint Commission, which itself was an organization inspired by Dr. Codman. And now that I think about it, maybe I understand why he wasn't entirely popular with hospital leadership. But the first set of quality measures we referred to as the SCIP measures, or Surgical Care Improvement Project. And these represented a paradigm shift in the way in which we think about surgical quality, because for the first time, we didn't think about surgical quality exclusively as technical skill, but we began to think about surgical quality embedded within a system of care. And so if we look at the SCIP measures, thank you, we can see that they really represent not characteristics of the surgeon, but characteristics of the hospital in which he or she operates. And it's striking to me as I look at these measures that they are by and large process measures, right? Prophylactic antibiotics received an hour before surgical incision, urinary catheter removal on postoperative day 1 and 2. These are process measures. They're not even outcome measures. For outcome measures, it took a little bit longer, and the introduction of what we refer to as, I'm going to need some more technical assistance, as NSQIP, or the National National Surgery Quality Improvement Program. Now, NSQIP was that next step forward where we began looking at outcomes, hard outcomes like survival or mortality, and proxy outcomes like, did the patient develop a pulmonary complication, a renal complication, a cardiac complication? Did they have venous thromboembolism? And this is now getting closer to Dr. Codman's vision of end results. Now, as I look at these, I think that this is closer to our vision in the Department of Surgery of what quality is. And yet I still feel like we might be missing something. Because if you look at a patient who's had a heart transplant, they care about whether they developed postoperative pneumonia, but that is not at the heart of why they underwent that surgery. And it raises the question, what do patients really want from surgery? And one conceptual model for thinking about this has been defined as 3 elements. The first one is safety. Do not harm me. Please do not accidentally remove my testicles when I have come in for surgery of an entirely different organ. The second is quality. Heal me, cure me, treat the cancer that caused me to come to you for care. And 3 is patient satisfaction. Be nice to me, and in that order. Now, as I think about what do patients really want from surgery, I can't help but think about the patient population that I have devoted my career in taking care of. So back in 2007, I created the Acute Care for Elders service here at the University of Colorado Hospital, which cares exclusively for geriatric patients. And when I began looking at what the experience of older adults is with surgery towards the end of their life, I'll tell you I was surprised. So it turns out that almost a third of elderly patients undergo surgery in the last year of their life. Almost 1 in 5 in the last month of their life. Almost 1 in 10 in the last week of their life. And that's kind of shocking to me, especially when you read the literature about what older adults value at the end of their life. So in this study, they asked geriatric patients about a surgery which would save their life, but which would leave them with severe functional impairment. And what they told the researchers is that 3/4 of those patients would not choose to have that surgery. So in that context, what do patients care about? What do geriatric patients care about when it comes to surgery? Well, it's not just these process measures, right? It's not even morbidity or mortality. Certainly, it's not like healthcare utilization. There must be other elements of the experience with surgery that patients value that we're not capturing well with our current conceptual models of surgical quality. And so that brings us to patient-reported outcomes. Patient-reported outcomes are outcomes that are measured from the patient's own words without the filter of a physician, APP, or a nurse interpreting what those outcomes are for the patient. These tend to focus in three domains: symptoms, function, and quality of life. And yet, if we look at our Vizient rankings, if we look at our quality reports from CMS, you will notice that these kinds of measures are noticeably lacking. I submit to you that this is going to change. This is changing already, and this represents the next seismic shift in surgical quality, from technique to end results as interpreted by us to end results as interpreted by patients. So, how are we seeing patient-reported outcomes in use in current state? Well, often we are most familiar with them as comparative effectiveness research. And maybe you could come up with a better example than comparative effectiveness research in urology, but I couldn't think of one. And so in honor of our next speaker, I have brought to you a comparative effectiveness analysis from the Cochrane Library on radical prostatectomy versus watchful waiting for localized prostate cancer. Now, for the traditional quality outcome metric, mortality, or mortality as a result of death from cancer, it is clear that there is a statistical significant improvement if you choose radical prostatectomy over watchful waiting. On the other hand, if you were to take one patient-reported outcome metric, something not classically captured well, which is distress from urinary leakage, now their story changes entirely, and it favors watchful waiting. If you sum all of the outcomes and ask patients about what is your global quality of life, your well-being, and that's going to include your distress from your symptoms related to the cancer, your distress from symptoms related to the complications of the operation, your fear of the progression of the malignancy, now we have a trend towards preference towards surgery, but our confidence intervals do cross one. What these patient-reported outcomes allow us to do, typically added on to more conventional metrics of quality, is get a more nuanced understanding of what is the impact of that surgery on that patient population. Now, these comparative outcome research studies have probably already begun to influence you in how you counsel patients, perhaps which surgical approaches you are taking, and maybe in the future, what operations are covered by insurance. So I told you that this is not just the distant future, this is happening now. And orthopedics has been our front runner in the patient-reported outcome space. Multiple orthopedic registries are already requiring reporting of patient-reported outcomes. And I found out last week that in the new CMS rules, they are going to require reporting of functional patient-reported outcomes for joint replacement and are setting goals for the level of improvement that they expect to see from hospitals. On a voluntary basis here in the United States, we are seeing collaboratives, which are sharing patient-reported outcomes, such as the Michigan Urologic Surgery Improvement Collaborative, and other countries for general surgery populations are requiring patient-reported outcomes in their registries. This is coming to the registries here in the United States for the type of operations that you perform. So what I find particularly fascinating is that patient-reported outcomes are not just another lens to examine end results. Collecting how our care affects our patients affects us as well. And this has been illustrated probably best in oncologic patients. The very act of systematically collecting their symptoms, their function, their experience, and feeding it back to the medical team causes them to change their care in ways that improves their quality of life and even hard outcomes such as healthcare utilization and even mortality. And this is profound. I want to say that again. The act of systematically collecting the patient's experience with their care causes us to change their care in a way that improves their outcomes. I predicted that this would be the next seismic shift in how we approach surgical quality, and this data suggests that it should. Now, while most of the studies demonstrating the impact of systematically collecting patient-reported outcomes have been done on oncologic populations, we do have some data in general surgery patients. So this study looked at collecting patient-reported outcome responses to surgical symptom-related questions for the kinds of operations that many of you here in this room might perform: prostatectomy, nephrectomy, mastectomy, with or without reconstruction, and thyroidectomy. So they collected these in the early postoperative period and flagged those of concern back to the surgical team. What did they find? They found a reduction in urgent care and emergency room visits. They found a trend towards reduced readmissions. And I find that interesting and might raise the question, like, why would collecting patient-reported outcomes change ED visits? And to understand that better, I think it would be helpful to look at some quality improvement that we've done here on the Anschutz Medical Campus. Specifically over in our VA with a geriatric population led by Dr. Teresa Jones and colleagues. There, they examined the reasons that patients would show up in the ED or would be readmitted and for how long they would stay in the hospital. And the first dominant driver, as you might expect, was infection, fever, sepsis. But the second and the third related to functional domains, physical or cognitive, that caused the patient's resources at home to be outmatched by their needs. And these collectively were more than bleeding, ileus, cardiac, pulmonary, or renal complications. In fact, functional domains drove more ED visits and readmissions than all of those combined. In addition, we did research ourselves looking at how do our surgeons perceive the integration of patient-reported outcomes into routine clinical practice. Now, in this analysis, we had 47 unique codes and qualitative interviews, which fit into 21 themes, which revealed 5 novel insights, of which I'm going to illustrate 3 here today. The first one is that patient-reported outcomes can modify individual surgeons' practice. So this might be at the level of counseling an individual patient. This might be at looking at their collective outcomes and using that to alter the way in which they counsel all of their patients. The second theme is that surgeons in our department believe that patient-reported outcomes represent the next step in patient-centric care and have the potential to improve shared decision-making and satisfaction with the care and communication that we provide. And we know that that satisfaction with the communication and care that we provide is something that we really need to be focusing on and looking for new ways to move the dial. But the third theme that came up was raising real concerns about how this data would be used. Inappropriate use of patient-reported outcomes to compare surgeons, especially across different surgery types, came up as a real concern. And we know with other subjective types of patient data, like patient satisfaction scores, that this can be influenced or biased by elements such as a mismatch between the ethnicity or gender of the surgeon compared to the patient. We know that measures like quality of life or wellness are influenced by social determinants of health. And so if we begin using patient-reported outcomes on quality of life to compare surgeons, will that begin to start showing these biases based on who cares for a larger proportion of patients who have disadvantages in social determinants of health? These are important issues to be thinking about as we think about how to use patient-reported outcomes. Dr. Laiti Abud and I were just named co-chairs of the UC Health System Committee for Patient-Reported Outcomes, and I assure you that we are mindful of the considerations that got poor Dr. Codman in hot water. So how do we position ourselves to be the best in the best possible position for this next stage of the evolution of measuring surgical quality? Well, I believe that we need to begin collecting long-term patient-reported outcomes, and that is in process already. We interviewed all of the Department of Surgery faculty, and of all the validated PROMIS questionnaires, which were applicable potentially to all surgical patients, there was a clear preference towards the Global Health 10-question survey. 71% of our faculty thought that this would be the survey, if any, that we should be sending to all of our patients. About 40 to 45% also were interested in a survey that related to specifically how is pain impacting your life, or one of two functional domains. And so we decided to thread that needle by having all patients get the Global Health questionnaire and then select patients who report problems with pain or function would get the additional follow-up questionnaire. Now, how can we use this data productively? I'll give you an example, and this is an example that we are working on right now. If we are asking every patient before surgery about their function, this allows us to take a look at a population level at which of our patients, before they ever undergo surgery, are already experiencing functional limitations, which allows us to target those patients for a novel prehabilitation program. You may use this to take a look at your patient's self-reported change in their quality of life after surgery, tracking their outcomes over time. You may use an analysis of your patients with a given operation and their end results a year out from surgery to counsel future patients about what to expect. But when we interviewed our surgeons, we found that they were not just interested in long-term quality of life. They were also interested in the short-term surgical symptoms. And so we would like to also collect short-term surgical symptom-related patient-reported outcomes. And no one wants to get 1,000 questionnaires coming to their inbox. And so instead of just feeding all of that data back to you in the electronic medical record, we thought that it would be helpful to have central monitoring, the virtual health center, looking at all of the outcomes in real time, identifying those of clinical concern, and only escalating back to the surgical team, the ones which are of significance. We are piloting this with pancreatic surgery right now. Finally, we believe that this is the next paradigm shift in surgical quality, and as such, we need to be at the leading edge. It is important that the Department of Surgery, the best department of surgery in the country, be seen as a thought leader in this domain. And so myself and colleagues, Dr. Sarah Tevis in surgical oncology, Dr. McGeed in CT surgery, Dr. Kim in urology, are applying for NIH R01 to examine what does it look like to centrally monitor patient-reported outcomes and intervene in real time for all surgical patients. And with that, I will conclude my presentation. Thank you very much.
We have time for one quick comment and one quick reply. Comment or question, I should say. Anyone? Okay. Dr. McIntyre.
I noticed in your in the study that was published in the Journal of Oncology that patients who were really asked about their better, but still 34% said they were doing well. So 66% are not. And how do we use those data to impact on their outcomes?
Yeah, I think that's a great question. Like, how do we know what's a significant response and which patients actually require intervention? It makes sense to me that patients undergoing chemotherapy for metastatic cancer, which is that study, are often not going to be feeling well symptomatically, but which of those need intervention? And that's actually an unstudied question. So they looked at a systematic review of colorectal surgery, and found that while there are a variety of patient-reported outcomes which are validated and could be used in that population, what is a clinically significant change in response is not well established. And so the surgeons have not clearly identified what is an important response, and that is going to be an element of our research.
Thank you, Dr. Cumbler. So, I always wonder, you fly on an airplane, you stay at a hotel, you do almost anything, and within 30 minutes of completion of whatever, you get a survey. And I'm surprised, the stakes are much higher in medicine, yet we have not really done this, and you look at all the top performing companies, services, whatever, they all do it. And I think you're right. In 10 years, this will be standard. And I think departments of surgeries and hospitals are just starting to think about it, but I think we're on the cutting edge of it. So thank you very much. Great talk.